All right, good morning, everybody. Welcome back to our second day at this conference on oncologic and hematologic topics. We have another really exciting and diverse program this morning and this afternoon, which I'm really looking forward to. Yesterday was excellent. I expect today to be just the same. Let me remind you, for CME credits, you need to sign in at the desk, both before this morning's session and then again after lunch. And presenters, if you're in the room and I haven't given you one of these forms, I'd like to ask if you would fill out this attestation form. It's, once again, part of the red tape to allow us to certify the meeting for continuing medical education credits. And once again, all of the presentations from this conference are being videotaped, and the slides that you're seeing here on the screen are to be embedded in the video, so that you'll have access to these slides as well by accessing the Binaytara Foundation website. So let's begin today with our first talk on acute myeloid leukemia, new updates, with Dr. Roland of the Fred Hutchinson Cancer Institute at the University of Washington. Dr. Walter, welcome.
Good morning. Thanks very much for inviting me, and it's my pleasure to start this second day with some updates on AML. And before I start, the disclosures have received some funding for lab research, for clinical research, and for some consultancy work. And the only thing that is relevant for this talk is the consultancy work with Pfizer for their antibody drug Mylotarg that I will get to at some part in the talk. So I thought I would start out by sort of surveying some of your practices and then sort of with 3 questions and then come back to those at the very end of the presentation. So here goes. The first question, for risk stratification and decision-making in adults with a newly diagnosed AML, what are you currently using in your practice? Cytogenetics at baseline, some molecular information at baseline, minimal residual disease information at some point after therapy, or a combination of the first 2 or a combination of the first 3. And let me see if I can get this going. Yeah, so let me try this.
You all have a question-answer clicker in front of you. If you could just press the power button and turn it on, and then select your response. He has them labeled A, B, C, or he has them labeled 1 through 5, but they're in letters on your clicker.
How can we see?
So once he starts, you'll see the option to...
We had this before, we practiced, right? So. Okay. Going on to the second question. For a 24-year-old man that is otherwise healthy, presents with fatigue and pancytopenia, and you diagnose him with an AML with adverse risk cytogenetics, he has a good performance status of 1. What is your first choice of therapy at this point? Either 7+3 using an anthracycline, daunorubicin at 60 milligrams per meter square. Your second choice, the same but a higher dose of daunorubicin. Your third choice is again 7+3 or gemtuzumab, ozogamicin, or Mylotarg with daunorubicin at either 45 or 60 milligrams per meter square. Fourth option is FLAG-IDA or azacitidine. And please make your choice. Okay. Oh, interesting. Okay. So I got definitely going to write this one down. 11, 7, 2, 1. Okay. So, and the final question. Now you have a 75-year-old smoker with diabetes, has pancytopenia, and you diagnose him with AML with complex cytogenetics. He's not in a very good shape. DCOG performance status is 3. And you have some other lab abnormalities, including a creatinine of 1.8 and an albumin of 3.2. For this man, what is your first choice of therapy? So what I would do in these 30 minutes or so that I have is to sort of give you an update on some of the molecular pathophysiology and how this can be used for risk stratification AML. And then sort of related to this, move on to minimal residual disease and how that could be used for risk stratification and perhaps treatment decision-making. And then for the second part, talk about some of the advances for AML therapy, both for medically fit and medically unfit patients. And at the very end, touch upon some treatment advance for acute promyelocytic leukemia. So starting off with the molecular pathophysiology and risk stratification. Even 5 years ago, it was very well known that AML is genetically a very, very diverse disease. It was also known that these genetic abnormalities have prognostic information, and you could lump some genetic abnormalities together into more favorable prognostic groups that are somewhere in the middle, or unfavorable groups, or even among the unfavorable ones, identify some patients by cytogenetics that have a very, very unfavorable outcome with this entity called a monosomal karyotype. And also 5 years ago, initially starting out by trying to learn more about these 40% of patients that have normal cytogenetics, it was known that there are recurrent mutations that are found in these patients. And the most widely ones focused on initially were the abnormalities in FLT3 with internal tandem duplication, the NPM1 mutation, and a mutation in CBPA. And it was recognized that they have prognostic information, and that if you combine this with information on cytogenetics, you can sort of refine. Let me try if I can get this, rid of this. There you go. That you can refine a risk stratification scheme by integrating these two aspects. And what I show on this slide is let me just see if I can do this differently here. This is going to get bigger. Oh, it's a little bigger. This is in these days, widely used risk stratification scheme developed by the European Leukemia Net, where cytogenetics and information on FLT3, ITD, NPM1, and CBPA is lumped together and put into a 4-group classification. And indeed, when you then go back into patients and you see, well, how do they do when you give them standard intensive chemotherapy, you can demonstrate that these risk groups indeed have significance, that when you look at large numbers of patients, they really separate them out nicely into patients that will do better and patients that do not so well. So this really gave glimpses of how complex AML really is. And I think the full extent of the genomic landscape of AML really became described with this one landmark study published 2 years ago in the New England Journal of Medicine, where a group of investigators, mostly from Washington University, have sequenced 200 patients with newly diagnosed AML. And what they found is that on average, an AML patient has 13 mutations. 5 of those are within a smaller group of genes that are commonly mutated. And the list is shown on the bottom right, and you probably can't read it, but many of these gene names will be very familiar from the literature: FLT3, NPM1, DNMT3A, IDH1, IDH2, et cetera. So these are genes that even in this large set of patients were found very recurrently. And by and large, a good portion of these genes comes more than once. And as was known before, alteration not just on the genomic level, but on like chromosomal levels are found very frequently in almost half of the patients. So I think this really defines how complex AML really is, and probably has identified the large pool of mutations that we will commonly encounter in AML. Now, just how complex this is on a molecular level was sort of highlighted by a second publication, also published in the New England Journal of Medicine around at the same time, where a group of investigators from ECOG have profiled about 400 patients that were treated on a relatively recent ECOG chemotherapy trial in AML, and they've looked at almost 20 genes in each of these patients. And this sort of wheel bar shows you that these mutations, they don't come at random. Some of them like each other, they come frequently together, like shown in these like white, red lines, like between DNMT3A and NPM1, and others are mutually exclusive. But it gives you an idea how really complex AML is when you look at more than one mutation at any given time. And I think people are still trying to understand what exactly the prognostic significance is of individual genes, and what becomes apparent is that it's not just relevant which gene is mutated, but also what other gene is mutated at the same time, and sometimes the prognostic information changes depending on in which context the mutation occurs. But unlike the scheme I showed before, this is not in wide use currently, but I think this is where the field may eventually be heading, is that you're learning more about these mutations and you start integrating them more and more and more into these risk stratification schemes, as done in this New England Journal paper, where by doing that, what they were able to do is, again, looking at the larger group of patients, sort of refine the ability to predict or to associate outcomes of individual patient groups and compare them to others. And as you can see on the slide, with doing this, you can identify groups that really do quite well with a very, very low risk of disease recurrence. And on the other hand, you can identify patients that will have an almost guaranteed recurrence of their disease. And I think the ultimately what this does, and this is sort of depicted on this graph, also taken from the New England Journal paper, is that it takes away patients in this middle zone where we don't really know what they will be doing, and we sort of put them more into the favorable group or the really unfavorable group, where we have probably a little bit of a better sense of what their outcomes are going to be. But so this study gives you some idea that if you're looking at larger groups of patients, that we can sort of foresee what the treatment outcome is going to be. But really the question is, well, how, now that we have all this information, we have all the genetics, we have all these many, many mutational data that and patients they come in your door and they bring in this printout from a lab, my doctor just found these 5 mutations, what does that mean? Happens more and more frequently. But now that you have all this information, how good is that for a given patient to say what is going to happen? Not as a group, but for an individual patient. And we did just that a little while back, and we asked this group of investigators that published the New England Journal paper to give us their data. And they gave us a data set of 300 patients on that study that survived the first month of treatment and had information on sort of the standard things like age, performance status, peripheral blood counts, regular cytogenetics, but then also they had information on all these 18 genes and whether they were mutated or not. And I don't want to go into details of how you do predictive modeling, but we used a methodology called area under the receiver operating characteristic, where you are trying to determine how well an individual or a group of covariates perform in predicting an outcome for a given patient. And for this type of approach, an AUC of 0.5 translates into basically a coin flip. It doesn't really help you. Versus an AUC of 1 is every time you're trying to predict, you're spot on, you're right. So what we found, excuse What you found is sort of depicted on this slide. When you just use sort of basic information, age, performance status, and white blood cell count, then we're really not that good even in predicting who's going to achieve a complete remission or not. So as you see, the AUC there is a 0.64. This is really not that different from a coin flip. And as you then become more sophisticated and you're adding genetics into it, you're getting better. You're getting up to a 0.7. And then you're adding information on NPM1 and FLT3, which is what I think every patient these days has measured. And you're getting a little better, 0.73. But then I think to us, somewhat disappointing when you then add these other 15 or 16 mutations, you're really not gaining that much. You're still at an AUC of 0.78, even for a very immediate outcome. So to us, that meant that even though we know a lot for groups of patients, for individual patients, we're far, far away from being able to really say what's happening to a patient. And that raises some interest in additional information that we could use to make us be better and more accurate. And one way of perhaps doing this is this concept of minimal residual disease measurement that has been in the focus of a lot of the AML research in the last several years. And the reason for this is relatively clear. For many years, the microscopic assessment of the blood and the marrow and the clinical exam of the patient has sort of been the standard of care for disease assessment in an AML patient, and achievement of a morphologically defined complete remission has sort of been the gold standard for success of AML therapy. Yet it's everyone who treats AML, this is almost a daily experience. Relapse is very, very common, even if a patient is in a morphologic remission. So that tells you that by morphology, we're really not able to detect amounts of disease that are clinically relevant. So over the last several, maybe like a decade or maybe a little longer, there's been several methodologies that have been developed that enable us to detect disease amounts that you would miss by microscopic assessment of a marrow or the peripheral blood. And the first two ones are sort of known to everyone, just cytogenetics and FISH. But they have limitations in sensitivity. And then as you go to the more sophisticated methodologies, there's PCR-based methodologies that can be used, very sensitive, but they usually only work for a small set of patients. Again, AML is cytogenetically and molecularly very diverse, so your molecular methodologies typically only work for a small subset of patients. And flow cytometry is currently sort of the methodology that can come around that limitation, in that it's able to identify abnormalities in around 90% of AML patients, regardless of their cytogenetics and molecular abnormalities. So that allows us to be relatively broadly inclusive in assessing patients with AML. And really the premise of measuring these small amounts of leukemia cells is twofold. One is that hopefully gives us a better sense of what a patient is ultimately going to do. Is he going to stay in remission? Is he going to relapse? And the second premise is that perhaps it could serve as a target for therapy. If you have residual disease by these methodologies, maybe you're a patient that needs more therapy than you would have given that person otherwise. Or on the other hand, if you have no evidence of residual disease, maybe you're a patient that doesn't need as much therapy that on average you would have been given. And I think there's been a flurry of articles in the last several years, and there's coming out many more in a very rapid sequence, that I think sort of demonstrate that the first of these two premises is true. That is, that MRD provides us useful information as far as prognostication in AML. And this has been shown for patients that undergo induction chemotherapy. That's been shown for patients at the end of induction and consolidation chemotherapy. That has been shown for patients before they enter an autologous transplant that has been shown for patients that undergo an allogeneic transplant. And at least in some of the studies, it's also been clear that even the smallest amounts of residual disease are prognostically very informative and relevant. And it's a big difference whether you're negative or minimally positive. And it doesn't make that much of a difference how much positive you are. And just to give you a few examples of how this looks in at least a clinical trial setting, when you try to use this as a marker that provides you prognostic information. These graphs are taken from a relatively recent trial conducted by one of the European groups, Roland and SOC. And it was a trial that has used sort of a double induction chemotherapy, nothing too fancy from the part of the chemotherapy. But what they were able to show in a large number of patients is that people that achieve a morphologic remission, even after the first cycle of chemotherapy, and you can see this on your top left graph, patients that at that time have no evidence of residual disease by flow cytometry, they are at much lower risk of disease recurrence, and this is shown in this blue bar, than patients that, even though they are morphologic remission, they still have evidence of disease. So you can distinguish these two entities early on within the first cycle of therapy, and as you look further down the line, you can show the same distinction when you look after 2 cycles of therapy, or when you look at the end of the entire chemotherapy sequence. And that's true for the whole group of AML patients, and this is shown on the bottom. It's true when you look at individual subsets of patients defined by cytogenetic risk. Like, it's true for favorable risk patients, it's true for unfavorable risk patients. And what studies like these have highlighted is that it's not just relevant whether you do or you do not have residual disease, but it also matters how quickly do you get there. And I think this is highlighted in this graph, where patients that only needed 1 round of chemotherapy to get into a remission, and at that time had no evidence of residual disease by flow cytometry, they're the ones with the blue graph, or the blue line, and they do the best when it comes to disease recurrence risk. But then as it takes longer to get into a remission, or it takes longer to achieve a MRD negative remission, sort of this risk of relapse sort of just progressively goes up. And that's true when you look at after completion of induction, and that's true when you look at a little later at the end of consolidation, and you're asking, well, if after induction you had remission or you didn't, and you were MRD positive or you weren't, you can separate out these patients very, very nicely. Sort of, again, highlighting the point that it really matters how fast you get there, probably as a reflection of how sensitive your disease really is. It is useful even in situations where we thought for a long time that we know what to do, and a disease subset that for AML has been sort of less of a problem are the core binding factor AMLs, so those that are characterized by the A21 or the inversion 16 abnormalities. Those have on average a relatively favorable outcome, and because of that we typically don't consider them for allogeneic transplant in first remission, and we usually tell patients, well, this is, it's not good to have AML, but if you have AML, this is one of the better ones to have. But we do realize that not everyone will do well, and there's a subset of patients that will relapse. And MRD detection seems to be a very powerful approach to identify these subsets of patients that will not do well, even though by genetics they should have. And this is data taken from an analysis from the UK group, from the MRC group, where they had almost 300 patients with co-binding factor leukemias that were in remission by standard morphologic criteria. And they quantified the burden of A21 or inversion 16 transcripts by PCR. And what they were able to show is that if you had a very substantial decrease in this tumor burden, and substantial in this study was like a 3 or 4-fold or 3 or 4 log reduction in disease burden from before treatment to after induction treatment, you essentially had a close to 0% risk of relapse. On the other hand, if the patient was in remission by standard criteria, but the reduction in disease burden by this PCR approach was only a log, as you can see, their risk of relapse was almost 100%, despite the fact that you were very quickly in a morphologic remission. And I think at least in our institution, data like this, and there's other studies that sort of confirm this, has led us to use this and to make some decisions around need for transplant based on these MRD assessments in this subset of patients specifically. And to sort of just highlight one thing, that ideally, I mean, we reserve transplant because we think we can't cure a patient with chemotherapy, right? Ideally, a transplant would be able to overcome residual disease. That would be the ideal situation. But of course, unfortunately, that's not the case. And I'm just showing some data that we're gonna show in 2 weeks at a meeting in Houston, where we looked at over 350 patients transplanted in Seattle, and we compared outcomes of patients that were undergoing transplant and they were in remission, and they had or did not have MRD at the time of transplant, or there was a handful, like around 50 patients that were transplanted with really active disease by all criteria. And as you can see on the slide depicted with the red line, if you have no evidence of disease by even fancy methodologies, your outcome after transplant is really relatively favorable. Your chance of survival is pretty good, and your likelihood of relapse is somewhere in the range of 20 or so, 25% over the first 3 years. On the other hand, if you are in remission, but you have some evidence of disease, again, these are the ones that we would like to cure because chemotherapy doesn't work so well, their outcome is really much, much inferior. And in fact, if you compare the outcome to patients that went to transplant with active disease, the lines are all essentially overlapping. So it's really not that big of a difference whether you have overt disease or you just have a little bit of disease. It really matters that you have disease. So that brings me to the second premise of MRDs. Is it useful to make treatment decisions? And I think the fair statement for AML at this point is there's no really stringently controlled data that would say yes or no. For acute lymphoblastic leukemia, on the other hand, there's now randomized data that really demonstrate that decision-making based on the presence or absence of MRD and basically up or down scaling your intensity of treatment does improve outcomes over time. We're not there with AML, and we're sort of dealing with relatively uncontrolled, smallish studies. But one that I wanted to sort of show, and it goes back to the core binding factor leukemias, is a study that was published by a Chinese group of investigators where they had about 140 patients with core binding factor leukemia, and in this case, it were only A21 leukemias. And what they were trying to do is assign patients to either consecutive courses of consolidation chemotherapy if they had no MRD, and the chemotherapies that were given are different from what we would use in the US, so it's not a one-to-one reflection of what we would do here. But the idea there was if a patient had no MRD, then you would just continue with chemotherapy. And on the other hand, if they had MRD, the idea was to get a patient to an allogeneic transplant. Now, there were patients that were sort of not complying with that plan, or a physician was not complying with the plan. So there were patients that should have gotten a transplant because they had MRD, but they didn't. And on the other hand, there were patients that felt, or the physician felt, that they should get a transplant even though they didn't have MRD. So this study had 4 groups of patients. And what they were showing in their data is that if you had a low-risk patient defined by no MRD at the time of remission, if you continue with just chemotherapy alone, the outcomes for these patients, again, these are small numbers, and it's not controlled, and there's a lot of bias potentially in there. The outcomes of these patients were better than when the patient went to transplant, presumably because the transplant-related mortality was more than the benefit you gain from increased disease control. On the other hand, for the patients that had MRD, if they underwent a transplant, their outcomes were better than if patients just continued with chemotherapy. So maybe a first glimpse that if we're making MRD-directed treatment decisions, we can ultimately improve our outcomes. So for the second part, let's move on to some of the advances of what actually have we accomplished for medically fit and medically unfit patients. And you realize I intentionally don't say younger and older, although for many of the drug testing efforts, it's still sort of dichotomized between younger patients, meaning fit patients, and older patients, meaning unfit. But even 10 years ago, and of course that's consistent with our daily experiences, there are older patients that are clearly medically fit. And even 10 years ago, the SWOG published sort of a really widely used paper on the relationship between age and AML. And even though the paper mostly highlighted the fact that if you're getting older and your ECOG performance status gets worse, then your likelihood of tolerating chemotherapy is really not that great, you could use the same data to say that, well, if you're older, and in this case, older than 75, and you're in good shape, just as estimated by a good ECOG performance status, your likelihood of tolerating chemotherapy is actually pretty good. So there are clearly subsets of older patients that one should not just call unfit and say, well, you cannot get chemotherapy. So with that, there's been a lot of interest in quantifying medical fitness and in identifying patients that, despite their older age, are actually perfectly suitable candidates for intensive chemotherapy. And I sort of summarize some of the efforts that were done over the last 10 years on this slide, and then sort of focus on one effort that we did together with Dr. Ravandi and other investigators from MD Anderson and investigators from SWOG, where we used a large number of patients, somewhere in the range of 2,200 or 2,500 patients, and we looked at a whole bunch of variables and tried to figure out, well, which ones are relevant to predict that a patient is going to do well or not do well with intensive chemotherapy, and how can you quantify this? And what we were left with was a model that included 7 things: age, performance status, platelet count, albumin, whether the disease was de novo or arose from another malignancy, chemotherapy, or an MDS, white cell count, creatinine, and how many blasts did you have in the peripheral blood. And that gave us we developed a model that's when you put in these 7 things, it spits out the number. And for those of you who've sort of talked more recently with AML docs at our center, you may have come across this number. We call it the TRM score. And what it does is it gives you a score that sort of translates into a likelihood of not tolerating intensive chemotherapy. And we use this very heavily in these days to make treatment decisions on patients, in that we use this to estimate how fit is a patient. And then with that, try to tailor the intensity of treatment that we have in mind for that patient. But I think it's important to realize that even 10 years ago, there's obviously 2 reasons why AML therapy fails. One is that the treatment was too toxic and a patient dies from consequence of the treatment. But the other part is that the treatment is not effective enough. And even 10 years ago, yes, there were subsets where the toxicity part was relatively substantial relative to the resistance part. But even then, for many patients, disease resistance was the main issue why a therapy didn't work. And I think the progress that we made over the last 10 or 20 years, and we made progress and patients do better with AML, are really related to our ability to get patients through chemotherapy more safely than we did before. And this is sort of highlighted by a study that was published again by investigators from SWOG and MD Anderson, where they showed very consistently across these two sets of patients that for every 5 years that you're looking at, even though the patients, they seem to have the same characteristics otherwise, they tolerate therapy better. They survive more likely the first month of therapy, probably as a result of advancements in probably especially fungal treatments, I would say, and maybe better use of transfusions. So with this, I think we can focus more and more on this issue of, well, how do we treat more effectively and worry a bit less of how toxic is it to patients. And as you know, in the mid-70s, this combination treatment of 7+3 with cytarabine and anthracycline has been introduced, and has so far, for most of the institutions, with some exceptions, has sort of been and remained the standard of care. And not because people didn't try. There were many, many efforts to try to improve upon this. And really, by and large, these efforts have all failed, and 7+3 has remained a widely accepted standard. So the few things I want to highlight here of potential advances is the addition of this CD33 antibody drug conjugate, gemtuzumab ozogamicin, or Mylotarg as it's known, when added to standard induction chemotherapy. So Mylotarg was known for many years that it has single-agent activity. But it took quite a while before larger groups of patients were treated together with upfront induction chemotherapy. And there's been now 5 randomized studies, 4 of those conducted in Europe, and they all differed a little bit on what regimen was used and how Mylotarg was given, and how it was sequenced and what the exact dose were. But they were all randomized studies. And even though they differed in some of the details, they all showed a very similar overall answer. And the answer was that if you add Mylotarg to standard induction chemotherapy, the outcomes get better. But they're not better for everybody. The biggest benefit was seen for patients with cytogenetically favorable risk leukemia. There was some benefit for this middle group of patients, and there was no benefit for the adverse risk of group of patients. Now the problem is, and I think this is probably one of the biggest advances in clinical AML research for newly diagnosed patients. Now the problem is Mylotarg in the US was approved initially based on surrogate endpoints, and it had sort of a conditional approval with the need for a confirmatory second study. And I'm skipping the details, but this confirmatory study, even though it showed some hints that this was true, that the benefit was there for favorable patients, by and large, as a whole, there was no benefit, and Mylotarg was removed from the market. So even though we have a drug that probably provides a benefit, it's not available at this point anyways. I think the second advance that is worth discussing is the use of a high-dose cytarabine-based treatment rather than 7+3. And well-controlled data for this come from the United Kingdom MRC group, where they have randomized a large number of patients, over 1,200, to either a standard 7+3, what they use 10+3, but 7+3 type chemotherapy, or a high-dose cytarabine treatment called Highdose, has fludarabine, high-dose cytarabine, and idarubicin in it. And what they were able to show is that across all subsets of patients, that the disease control is statistically significantly better So the CR rates are better, and the event-free survival is better. But there is a problem in that the treatment is somewhat problematic to give, and the overall survival, at least at the time the analysis was published, was not different, presumably because some of the survival advantage was offset by the increased toxicity. But just when it comes to leukemia control, this seems to be more efficacious than a 7+3 treatment. And then I think I need to discuss this idea of daunorubicin dose escalation. Looking at the responses that you had in the initial question, that is something that you have thought about. And as you probably all know, or many of you know, there's been several large studies that have randomized patients between a higher and a lower dose of daunorubicin. And 2 of these studies were published in the New England Journal of Medicine. They were very prominent. And they both showed that for younger or older patients with newly diagnosed AML, if you're using daunorubicin at a dose escalated level of 90 milligrams per meter square, the outcomes were better than in the control arm that used a dose of 45 milligrams per meter square. And there's been a maybe less widely known study from Asia that has sort of shown the same thing. But the problem with this is that in 2015, the standard of care is not daunorubicin of 45, but it's daunorubicin of 60. So the question is it really better than daunorubicin of 60? And there's a study that was just published a few months ago, again from the United Kingdom Cooperative AML group, that has randomized about 1,200 patients to either daunorubicin of 90 milligrams per meter square or sort of the quote-unquote standard of 60. And the scheme of the trial is shown here. In the MRC trials, they're always complicated. They have all these different randomizations in them. It's very confusing. But if you just focus on the first randomization between the lower and the higher dose of daunorubicin, in their hands, the outcomes are entirely overlapping. So in their hands, among 1,200 patients, there's no difference between 90 or 60. That doesn't mean it's not between 45 and 90, but there's not between 60 and 90. So maybe what was thought to be an advantage or an advance is maybe not so much of an advance. And I want to finish off with the intensive treatments by mentioning all these small molecular inhibitors. And with a disease as diverse as AML, there's obviously a huge interest in coming up with small molecules that target individual patient subsets. And we're still at the relatively early stage. There's many of these drugs are in clinical testing, and there's some data being presented at meetings and being published as sort of early phase experiences. And some of them, they are benefits published, but I think it's too early to really say how they will fit in. And I sort of want to leave this with sort of a cautionary note on this idea that we know exactly who to treat. And maybe this becomes obvious with this study that was presented last year's ASH meeting at the plenary session, where patients with newly diagnosed AML were treated with 7+3 standard chemotherapy, and they received or did not receive sorafenib, which is used in the clinic as a FLT3 inhibitor. And there indeed was a survival benefit, at least with regard to event-free survival, but only 17% of the patients actually had a FLT3 ITD, and the benefit that was seen in the study was independent of the FLT3 ITD status. I think it's a reminder of that. Even though we may have soon a lot of these drugs available, we really have to figure out which patients are those that benefit most from these drugs. So a few points on AML in older patients is obviously the large number of patients, because the median age is 75 at diagnosis, so most of the patients are older. And when you look in the SEER data, and I didn't realize this before I looked, it's a lot of the patients never actually see therapy. There's estimates that about 50% of the patients that are older than age 65, they never receive AML therapy. And if you look at patients at age 80, it's only 10 or 20% that get treated. And of course, the challenge that is perceived is both that the disease is difficult to treat, and the patients have a hard time tolerating the therapy. But as I showed, you can identify some patients that are medically fit, and those are certainly appropriate candidates for intensive therapy. But if you come to the conclusion that a patient is unfit, what might help is to get some sense of what the prognostic factors are, the cytogenetics, the molecular data, because that may give you some guidance on what to do. Is a patient population where a clinical trial should be your first choice if you can. And if you don't have that available, then a standard therapy makes sense. Although standard, I put this in quotation marks because there really is not an established standard. Perhaps with this study that was just published in Blood a few months ago, physicians may lean more and more towards using these hypomethylating agents for AML patients. This is a study that has randomized patients between azacitidine and a choice of something else. And the physician had to decide for a patient, I would give him either intensive chemo, no therapy, or low-dose cytarabine, and then the patient got randomized to either that or azacitidine. And what this study showed in almost 500 patients is that the outcome with azacitidine is slightly better than when you use sort of this conventional care therapy. But when you look at the slide, the outcome, I mean, it's not like a black and white difference. There's a little bit of an advantage. But maybe data like this will lead people to think more of azacitidine as the sort of standard for AML therapy. So before I come back to the questions, just one update on APL, a disease that we really don't see that often, at least in this area of the world. And we think of being pretty able to cure a large portion of patients with a combination of ATRA and chemotherapy. But a recent study has picked up this idea that perhaps we can abandon the idea of using chemotherapy altogether. And what this study has done is has randomized patients to the standard in APL therapy, which is ATRA and anthracycline chemotherapy, versus a combination of ATRA and arsenic. And what this study was shown and was published, I think 2 years ago in the New England Journal of Medicine, is that if a treatment approach that avoids chemotherapy for low-risk APL, that the outcomes are at least as good and probably better than the chemotherapy ATRA-based treatment. And in fact, there's now longer follow-up, and I think these curves have separated a bit more. And I think it's fair to say that ATRA-arsenic at this point is the standard of care for low-risk APL. So to summarize, AML is very diverse as a disease. We know a lot about it. We know genetics. We know molecular markers. Many of them we do use. Many more are probably on the horizon. I do believe that MRD is very helpful, and we should use it. And we should use more quantitative measures to decide who is fit, but we should treat everyone if possible. With the advances I want to highlight is the addition of Mylotarg to 7+3 chemotherapy, Highdose, so Highdose cytarabine-based treatment, and perhaps sorafenib, as I showed you in this early data. So just to have the time to go back to these three questions. So if I can go back to, okay, now I'm going to screw this up. So if I go back to these questions. So the first one was, well, actually, we can skip this because you were pretty good in this one already. So let's coming back to the treatment options for a medically fit adult with AML. It was a pretty wide distribution of ideas that you brought up before I started. So when we revisit this now, what would you choose now? See if I can actually hold on. Can I get this too? We may be stuck with it again. Oh, okay. So I think now you can make your choice. Okay, let's see. All right. Oh, okay. Interesting. So I didn't convince you of the flag so much, but I did convince you that maybe 90 is not the way to go. Okay, good. That's interesting. All right. So let's see if I can get back to this. This really is not complying very well. Yeah, no. I need to go back to the question.
Oh, this got turned off.
Oh, okay, that would explain it, I guess, huh? Oh yeah, okay, good. So the other question, so now you have a medically unfit patient, an older individual that's medically unfit. And so your choices here between best supportive care, hydroxyurea, low-dose cytarabine, azacitidine, or induction chemotherapy with 7+3. Let's try this. And sort of this was the one that had the biggest diversity in answers the first time around. Let's see. Oh, okay. So now this has clearly shifted. Interesting. Good. Okay. So I think with this I'll stop, and I don't know. Do we wait until the end? Okay. What?